Welcome to the Two Echidnas podcast. You're with Mon and Don.
Two advanced practice nurses with decades of experience in hard-to-heal wounds, burrowing into prickly conversations.
Welcome to episode 2 of the Two Echidnas.
Great to be back.
Yeah, it's really weird saying that name, but still love it.
I think it's going to get easier as we go along.
Yeah.
Fantastic. We're sticking with the echidna.
Yeah.
So thanks for joining us back again.
Yes.
And for episode 2, we wanted to think about the people who are really listening to us predominantly, which is going to be clinicians. And we wanted to talk about the important role of clinicians and the importance of caring for clinicians.
Yeah.
And be a little bit prickly in the ways that we do that. I guess because we are privileged to come and work in quite complex teams, and there's challenges in that. There's a lot of emotions in that sometimes. And one of the things we often talk about when we're doing the debriefing and, benchmarking with each other and supporting each other. I think we're going to talk about supporting a lot more as well. That's one thing I think is not spoken of enough in how do we support each other and do we make ourselves open to being supported? Because that, I can certainly say that improves my clinical practice.
Peer support.
But how are we looking after those teams when we talk about person-centred care?
Yeah. I think for me it's been something that's I think people who know me have heard me say, again, prickly, I don't believe in person-centred care. Of course I believe in person-centred care. But I think sometimes the people that get lost are all the other people around that person. And too many times we see carer stress, clinician stress, and we say, oh, yeah, carer stress, and yes, they're going to go for, the client, patient, resident is going to go for respite. And we sort of talk about it. But do we really care for the clinicians that are involved in that person's wound care? Again, from a holistic perspective. And especially around when there are arguments, and they can become arguments about what dressing product to put on.
All the time.
I've had a director of nursing ring me, and the indication for calling me into the organisation is because 2 of the staff have gone on stress leave because there'd been this friction over the dressing application and the dressing prescription for someone. And by the time it gets to that stage, I think there's been a lot of non-caring in our caring profession. So for me, and hopefully we'll explore it further, is caring for the carers and the clinicians.
Because ultimately I actually believe that cares for the client.
Yes.
By default.
Yep.
And it's certainly a space I work in a lot of. Again, we talk about, it was in one of the podcasts we were listening to yesterday in preparing. It's wonderful for us to say, let's get called in earlier rather than later for the client. It would have been great. Maybe we could have avoided that 2-year-old venous leg ulcer or that amputation. We want to see them earlier. We want to do those assessments. Prevention, absolutely. But why are we being called in so late when the people, the nurses, the clinicians, are pulling their hair out, are burnt out, when the client sacks them? I have a lot of clients who sack their clients, and they can. This is the disability space we work in. I don't want to have you back anymore. I don't want that service back anymore. And it's just been so eroded. This is like almost a weekly thing for me when case managers or support coordinators have to repair relationships.
Yeah.
So where are we early on in those stages? Because at the end of the day, when things like that happen, that doesn't translate to great wound care.
And when we were talking last episode about burrowing, part of that burrowing process is working out what are the relationships between not only the client, patient, we're going to have the person with the wound and their care team, but also what are those relationships within that team itself. And again, trying to figure out what dressing to put on that person is the last thing on my plate at that time. I'm thinking, hang on, have we got team cohesion? And most importantly, do those clinicians have the support of their managers? And often at a middle management level, middle managers are trying to do their best, but it's push from the top down. And so when we're talking about that dressing, that full stop at the end of that sentence, that
I love that analogy. I've pinched that, as you know.
you know, like there's a lot that has to happen, and that's part of the reason why sometimes people chop and change dressings. And so whenever, when you're talking about the client being sacked, the client sacking their care team, that's always, I think, as advanced practice clinicians, in the background or even the forefront of our minds, and thinking about, yes, I've got to put this plan of care in and advise this on this particular person with this wound, but in the background, I've always thinking, geez, this could go pear-shaped very quickly, and what are the implications for the care team? There are always high performers and low performers in team, but the net negative impact on that team and the confidence they lose to progress further. So I'm always thinking about the team and how it's all going for them. So I know it sounds really, sometimes it seems almost fake when I say, oh, you've done a great job, but I really mean it. They've often done a great job. There are poor performers. There are, poor performing teams. But I don't know where the reality is there. Where are the truly underperforming teams in wound management?
That's tricky. That's controversial. I think we're getting into that area. When you've said that, what comes to my mind is, and again, I'm working a lot in the disability space and I thoroughly enjoy it because often it's that person-centred care. They're really at the centre. But what I'm noticing is missing, and I'm more than happy to be corrected, is care teams. I'm talking about disability support workers and teams that go in to see people. They're often matched to the consumer, to the person with the wound or the wound. Often it's wound prevention, skincare, whatever we're going in. They're often matched. Do their personalities match? Do they resonate with each other? Is it a good match? And people can be taken out because it might not be a good match. That happens a lot in the disability space. Does that happen in a nursing space?
No.
Yeah. And I've just had that epiphany as we've been talking.
Oh, yes.
Why don't we do that? So why aren't we saying it's okay actually if – we don't want to pick and choose between who we see and don't see. I'm not talking about that. And I know, managers working in community nursing will very strategically, allocate nurses to go into certain people. But I feel as though in the last 10, 15 years, I was first a district nurse well over 20 years ago. I feel as though that whole primary nursing model has changed so much. And I'm not in that space now, so I'm not going to critique it and pretend to say that I know exactly why that's changed. But I can tell you I come into so many difficult situations where the person with the wound or the family is so desperate and they don't want, I'm just going to say it, they don't want those community nurses to come back in. I'm not saying they don't do a great job.
Yeah.
They absolutely do, but there's a lot of them that come my way where they have 10 people coming in. They don't know who's coming on what day and they're all doing it very differently and it's exceptionally task-oriented. And who's matching those people up and checking in with the client? And why aren't we actually saying, well, this is your team of 4 or this is your I find that translates to a lot of frustration and I see a lot of chronic wounds in that space, a lot of chronic wounds.
So what are they doing in that disability space that they're not doing in community care? Because I'm thinking about the logistics. How do you roster around that? You've got part-time employees.
Nightmare, 100% nightmare. But you've often got, what I'm finding is you've got regular people going in, a team of people who are identified as your team, and there's that opportunity for the participant, injured worker, etc., to feed back and say this person's not working out.
Yeah.
I don't know that we get that opportunity. It's
But do you know what happens? I think in the public space, in the community space, that happens by default. So, managers often say to me that, and it's legitimate. It's just hard to roster around it. You've got part-time
we don't have the
workforce.
resources for
We
it.
just
This
don't.
is public health too.
Yeah, but what happens when the rubber hits the road, or when the proverbial hits the fan, when there are pressures on that service, they somehow manage to do it. But I think that's at the disadvantage of other people, other clients in that service. And so they may sort of get a sort of a haphazard team together. We're saying, oh, look, the key contact people for this particular person. But that's usually a reactive thing, not, in response to a disaster rather. And and again, how do, clinicians working at the bedside, at the home, in the home, they don't have any control over that.
Is it a case management type model that we're missing for those hard to heal chronic wounds? Because in that space where there's, disability support workers that might not be working out, or where there's issues with incompetence or whatever. And I just want to add the comment too that a lot of people in that space, I think it's the team that makes or breaks their quality of life and their care, whether they've got a wound or not. But I just don't think we talk about it so much. But they usually have a central person who they can get back to, and we're putting the impetus on the person with the wound to then either make a complaint or have that difficult conversation, but we're not allowing that so much. It's hard for them to do that because they don't want to complain. But often when the likes of you and I go in, they know exactly what's not working in their team of people doing their wound care or their wound prevention or whatever it might be. They can be really articulate, but they haven't been enabled to verbalise that up. And I guess we're very experienced and we can get them in that position where they have that bit of trust. Maybe we're impartial. We have the time to spend as well. I often feel very privileged in that space where, so absolutely acknowledging the limitations that many other clinicians have. But is that a reason? How are we working to fix that? Because we've been having these conversations for a long time. These aren't new issues.
Yeah, and I think, we're talking about echidnas, but the Tyrannosaurus rex in the room is our depleted workforce. I found myself, and it was pretty defensive statement, but recently I had, just recently, in The Age a few days ago, they reported on, I think it was, let me get the figures right, something like in 2021, 9,500 nurses left nursing, and that was 1,500 more than the previous year. And look, I think that's around the stats. And then, you've got people saying, well, I don't want this nurse, I want this nurse, or I don't want this clinician. It's a systemic issue. And hopefully podcasts like this, these podcasts will start reaching out to some decision makers and hearing what the real issues are. That's aspirational, but 100%. You just never know.
I'm reminiscing of a significant something that's stuck in my mind in the last couple of months. I've had we're not talking giving away any confidential information here, but I had a client who had been waiting for wound debridement from a service, and there was only one person in the service who could do it, and it took over 2 months, and they still hadn't come out to do it. And of course, we could talk about the merits of one-off debridement versus serial debridement. I think a one-off's going to do it in this situation. But that wound needed some significant activities around debridement, obviously not just that once-off debridement. It's not just putting a blade or a sharp instrument on a wound. When we're talking about debridement, it's managing the whole thing. But to wait 2 months for someone to come and do one debridement, because I just find this skill in some of those teams has changed a lot. And I think post-COVID has highlighted that. There's been a lot of people a lot of knowledge that's been lost.
And that's a really, I mean, I think we could dedicate, 5 podcasts on debridement, and maybe we do leave that for another time. I don't know. I mean, if you want to explore that, because I think that for me, the risks of not debriding over 2 months, far. I don't know whether anyone's done any, well, they have. There's been research out there, but, the mortality and the morbidity associated with not debriding. Yeah, we all fear cutting a tendon or, well, we don't fear it, but there is this, or maybe people do, but there's this unrealistic fear of it. And we're so risk averse now, that
Very
we're
much
not
so.
doing the care that we need to be doing. And doing a lot of work before you're being asked to, can you teach us on debridement? A hell of it, we could talk about that.
Well, it's a bit, and I think we need to put in that same bucket of we need to talk about that later. But the dangers of not doing it, are they far greater than the dangers of doing it? Compression. Yeah. How do I compress?
Yep.
Yeah. How do people learn that? We don't want to do it because, we can't afford that material, or we don't have enough skilled clinicians to do it. Or there's clinicians in the team that maybe the doctor says yes, no. There's just lots of peripheral people are saying yes, no. I've had situations where clinicians have argued where there's 4 or 5 different clinicians involved and they can't decide. But the dangers of not doing it are meaning a deteriorated leg, a deteriorated wound. That then gets harder for us when we finally navigate ourselves into that position where we can do it. It's more difficult, yeah.
And so going back to always in the background, in my role, I've got to, well, it's part of my role, which we'll talk about in subsequent podcasts, I suppose. But my thinking is someone may come up to me and say, can you teach me to debride? And sometimes caring for that team is saying, well, no, because there are other things that you need to be doing. And if you're not doing them, there's no point, again, focusing on the last word before the full stop.
Yep.
Think about all the other things that need to happen. And so it's tough love, I suppose.
It is.
Or tough caring. I don't know what we're going to call it. But and this cord keeps playing. That's why I keep twisting my head. It's I'm saying no for a clinical reason, that best practice dictates that we've got to do a lot more. That's often not as sexy.
It's very much not as sexy. I agree. I would
it's
be saying
simple.
I would be saying no, that's not the right timing yet to do that therapy when we haven't done other fundamental strategies, like the hygiene.
Yeah, or you're asking me to teach you how to debride, but the reason why this wound has got to that stage is because, as you were talking about, inappropriate wound hygiene, inadequate arterial assessment. Notice I didn't use the word vascular. Another topic.
Definitely. We're going to peg that one for later. Yep.
So a lot more has to happen downstream. But so many times I've tried to teach those unsexy things and, you get poor attendance at that. But then when you run debridement courses, everyone's at the debridement courses. And again, it's a debridement course separating the difference between education, training and competency, being competent to perform debridement and what that means. But, so for me it's saying no. I'm happy to teach you debridement, but can I also teach you all these other things?
I guess in our roles too, and I find this, we always have that I want to teach you something mentality. So even when we're going in there and we're doing that client-centred care, we're not off as consultants, we're not – I mean, in private practice, that's a little bit different for me. Often I am the only one in there, but many times I'm still working within a team of a variety of different skill levels and other clinicians, including allied staff. But we're always wanting that educational focus to support them and look after the clinician because that's transferable I will often have a lot of people. I've had this happen twice last week where they're coming to tell me what they think should happen with the wound care, which I need to bite my tongue because often what they're saying is wrong. But people are well-meaning, but how do I look after them? How do I support them and say, well, actually, no, that's not right? And assert yourself as the person who does know what should happen and maintain those relationships between clinicians. There's just so many moving parts when you're in those complex wound situations, and I absolutely agree. I forget the dressing. I often find it's not even the full stop at the end of the sentence. It's on the next page. Yes. And if you actually fix up all those periphery stuff at the start, like who is actually in the care team? And I will often bring in and kind of, I was going to say push out, but I will often bring someone to the fore or put someone more in the background or try to orchestrate that a little bit for my wound or edema issue that I'm trying to get resolved. Because, well, I'll give you an example. So I had lovely OT who was writing the care plan for lymphedema, and I've been involved with this particular participant for 18 months, and I was never consulted. And yet this care plan's gone out to the team with quite complex instructions, and the communication's not there, and I've had to go in and really assert my role and say, actually, that's clinically not right, and I wasn't consulted. This is actually a bit dangerous, and the wrong garments were being used. So sometimes you have to navigate who's in there and your relationships to get to the better client care. But that's actually, it's really challenging to do. Like, I'm always just taking that step back of reflection and thinking, well, we've got to be really respectful sometimes in the way that we have these conversations. But if I don't have a difficult conversation, I'm also not doing my job and helping the client. Yeah. And often the clients don't see all the stuff that goes on in the background. I think if they do see some of this stuff that goes on in the background, they would be shocked. But I don't like it also when the client does know that there's challenges between clinicians. I've had a lot of my clients, people with wounds, who have been very hurt, and their trust in their team's been very eroded by differing opinions, and that's hard for them to navigate. I often talk about the noise of wound care. That's noisy stuff that we don't manage well because we get a bit territorial.
And where does that holding a clinician to account, so more around that clinical governance, holding that person who, well, not so much holding to account because that sounds almost punitive, but how do you have that conversation with the OT and have that difficult conversation that was the poorly prescribed compression garment or compression device, whatever, the patient over here and then the care team? How do you care for all those people?
I had to absolutely be the echidna. I was the prickly one.
Yeah.
I was the prickly one. You've got to know people, and you've got to be prepared to pick up the phone. Yeah. And build a bridge.
Yeah. I wonder how echidna parents look after their young. We'll have to look at that.
We did learn that the puggle.
Oh, that's right, a puggle.
They're like a little jelly bean. That's right. But the baby echidnas, they're called Puggles.
Yeah. But did we learn about how they look after the young?
No, we didn't. No, I think we need to go and...
Yeah.
Because I'm sure there might be some good analogies there, because we're often looking after younger clinicians who are learning. And I find maybe it's just the space I'm working in largely at the moment, but I would easily have between 5 and 10 people contact me a week saying, how can I become a wound clinician? How can I specialise? Don't get me started on that word. That's prickly. How can I specialise in wound care? How do I do what you're doing? Where do I learn? What's the one best course for me to do? Oh, boy, and I answer that one. There is no one best course to do. Let's start the whole conversation around professional development. Because I have so many people ask me those questions, I've got to really check myself and reflect in my replies, because I am sure the amount of people who think it's just that dressing focus and they see the fancy bit of work that we do, but they're not wanting to wash the legs. They're not wanting to do those wonderful things that we love that are foundational to that wound care.
Well, we're very willing to put, say, negative pressure wound therapy on someone. That's the easy bit, but making sure that that bony prominence is offloaded, the person's eating a healthy diet, all those the simple things.
Have
the
all those
skin's clean and dry.
referrals been done.
Yep.
100%. Yep.
And also just talking about Puggles then, and how are we going for time here?
Yeah, I think
we're
25 minutes.
Okay.
Yeah, people are still listening.
Yeah. So about Puggles, and I'm going to twist that term around because it's your idea. Well, I think it was your topic or your idea initially about how we puggle-ise or infantilize.
It's a great word, puggle-ise.
Puggle-ise wound management and the broader profession of the health sciences, which are predominantly have women in them, but sort of having. I think we'll leave that for another topic. But
yes, let's talk about that. Yeah, that's a great.
But that analogy, infantilising, puggle-ising.
That's still in that topic of looking after clinicians, raising awareness
and
of
respecting
wounds and edema,
and respecting
and bringing out the best in people, and also acknowledging. I think we talked about in the last episode, we're always learning as well. We never stop learning.
Yeah.
And it's, for me, it's refining my practice in order to support others and bring more Puggles into the world because, we had someone who mentored us earlier on in our journeys. We've had many people, one person, but one in particular would always, talk about who's going to do this when I'm gone.
Yeah.
And I can remember hearing that a lot, thinking, well, when you're younger, you don't think about that kind of thing, immortality anyway, and you're just thinking in the moment. But as I've been a nurse for 30 years now, that's just ridiculous. I don't know how that happened.
Yeah.
But you do realise when I'm not here in 10, 20 years' time, where's my knowledge going to go if I'm not actively assisting others? Because I would say that so much that I learnt even 20 years ago, and when we were talking about this yesterday when planning some of these episodes, where do you go to learn the things that you'll always go back to, that you'll need? I'm still going back to some of those experiences and learnings often in what I'm doing at an advanced practice level that I learnt 20 years ago. And I'm not talking about clinical info that's been updated, that, contemporary evidence changes and keeping up with that. I'm talking about really foundational things. So, there's a lot in that episode, I think, Mon, that we've covered off. I hope it's resonated with a few.
Yeah, I think, we've sort of had conversations about where we're going to take this next, I suppose, and we will talk more about our backgrounds in future episodes, but also what are some of the more controversial topics. We weren't going to launch into it straight away. Hopefully we've given people an opportunity to hear where we're going to be taking this, but it hopefully becomes a bit more, well, not more, but it'll become edgy and hopefully get people thinking about not only the broader skill and specialty of wound management and the number of people that work in teams that have wound management skills. It may again be controversial there because I think nurses have a big part to play in it. But again, because we really are a predominantly female profession, we're sometimes infantilised, and sometimes the contributions that we can make are often not considered or regarded. Like your the other day when someone said to you, they're telling you what they think you should bring in. And of course it happens with other professions.
Yep.
But there's too many times where I think there's a we know a gendered issue around what nurses do and what we contribute.
Yep. No, I couldn't agree more, and I think some of that's tied up in the misunderstandings about what wound care is. It's not those tasks. They're expecting us to do a certain thing, but in actual fact we're often coming in and we're unpacking a lot of these issues around the periphery. We're digging and we're using all our claws, all our full feet.
Yes.
So let's leave it there.
Yeah, I think
Thank you. There's a lot of prickly issues in there, and we'll definitely unpack a lot as we keep going. So thanks for listening. And
thanks everyone.
Come back for episode 3 soon.
Okay.
We are so grateful to have this opportunity to share our learnings and challenges with you today. Hopefully it has inspired you to be more curious in your clinical practice and burrow down to issues that bug you. If you liked today's episode, follow and subscribe on Spotify, YouTube and TikTok at @2echidnae.
If we were too prickly, we'd also like to know. All our contact details and links we've mentioned are in the show notes below. You can also help us by leaving a review and sharing this with your colleagues. We will see you in the next episode, and in the meantime, go forth, be curious, and burrow into some ant nests.